Welcome to a series on falls prevention. This is Module 1 of 4, an Introduction to Falls Prevention. This module is brought to you by Surge Learning. It can happen in an instant, reaching on a wobbly stool for something located on a high shelf, tripping over uneven pavement, slipping on a rug or a patch of ice, or getting up from a bed, a bath, a toilet, or chair. It can happen in a person's home, in the community, while a patient is in the acute care hospital, or as a resident in a long-term care home. A fall is often defined as a sudden and unintentional change in position, resulting in an individual landing at a lower level, such as on an object, the floor or ground, with or without injury. A near fall, or a near miss, is a sudden loss of balance that does not result in a fall or other injury. For example, if a person slips or trips but does not fall. Falls remain the leading cause of injury-related hospitalizations among Canadian seniors, and between 20% and 30% of seniors fall each year. Falls and associated outcomes not only harm the injured individuals, but also affect family, friends, care providers, and the healthcare system. Serious injuries may include fractures, such as the hip, ankle, wrist, or upper limb. Lacerations, which require sutures. And any injury requiring assessment in emergency or admission to hospital. We do know that these personal and economic costs can be avoided through injury prevention activities. There are numerous ways that a person can suddenly trip or lose his or her balance, and the result is often injury, hospitalization, or even death. There are several risk factors that can affect a person's fall risk, including biological, behavioral, environmental, and socio-economic. We will be looking at these in more detail in the following chapters this series. A study on senior residents living in the community showed that 27% of elderly individuals with one or less risk factors experienced a fall, and 78% of the elderly individuals with 4 or more risk factors experienced a fall. A fall can cause psychological damage even if the senior is not physically injured. Fall researchers describe a fear of falling cycle in which after a fall, seniors become so afraid of falling again that they limit their activities. This, in turn, decreases their fitness, mobility, and balance, and leads to decreased social interactions, reduced satisfaction with life, and increased depression. This fear cycle then increases the risk of another fall. This series will explore factors that contribute to fall risk and look at preventative measures. The personal, medical, and economic toll of falls in Canada is great. Falls are the second leading cause of injury-related hospitalizations for all ages and are the most common cause of injury for elderly people. Falls accounted for 57% of deaths due to injuries among females aged 65 and older, and 36% of deaths due to injuries among males. Falls are responsible for 70% of injury-related days of hospital care for elderly people, and are accountable for 40% of all elderly admissions to nursing homes or long-term care facilities. Through assessment, a person's level of fall risk can be determined by evaluating the various risk factors present. By identifying the potential risks, preventative measures can be implemented to reduce the frequency or severity of falls and fall-related injuries. Stay tuned as we explore this in Modules 2, 3, and 4 of this series. Thank you for joining us. This concludes an introduction to fall prevention. In this presentation, we discussed the definition of a fall, near miss, and serious injury. We discussed some statistics relating to the rate of occurrence and hospitalizations, and we took a glimpse at economic costs of falls in Canada. Welcome back to part 2 of our falls prevention series. This module will focus on fall risk factors in seniors. The risk of falling increases as a person ages. However, falling is not an inevitable result of aging. Falls result from a complex interaction between various risk factors. There are 4 major categories of fall risk factors in seniors. These include biological and medical, behavioral, environmental, and socioeconomic. We will be starting our discussion today with biological and medical risk factors. Biological risk factors include those pertaining to the human body and are related to the natural aging process, as well as the effects of chronic, acute, or palliative health conditions. Biological risk factors include advanced age, decreased mobility and balance, muscle weakness, visual impairment, acute or chronic illness and disability, for example, cognitive impairment, stroke or arthritis, Some conditions cannot be changed, such as gender or age, while others may be prevented or compensated for, such as muscle weakness and poor vision. Chronic conditions include stroke, Parkinson's, arthritis, hypertension, osteoporosis, and cardiovascular conditions. Acute conditions which affect one's risk for falls include urinary tract infections and other infections that may cause weakness, fatigue, or dizziness. Biological and medical risk factors also include cognitive impairment. This includes impairments with orientation, memory, executive function, visual perception, and information processing skills. Next, we are going to focus on behavioral risk factors. Behavioral risk factors for falling include actions, emotions, or choices of the individual. Behavioral risk factors include history of falls, fear of falling, poor nutrition and/or hydration, lack of physical activity, inappropriate footwear and clothing, and taking multiple medications, particularly psychoactive medications like tranquilizers or antidepressants. We will look at these in more detail. The best predictor of a future fall is if the person has a history of falls. The previous fall might reduce the person's mobility status and induce fear towards participation in activities of daily living. Fear can motivate some to take precautions against falls, but in others it can result in decreased participation for activities required to maintain self-esteem, confidence, balance, and strength. Participation in activities that are high risk, considering the person's physical and/or cognitive status, can be a risk for falls. This might include trying to walk or transfer without assistance, or getting in or out of the wheelchair without applying the brakes first. Inappropriate footwear such as shoes with worn soles, loose laces, and a higher heel increases the risk for falls. Long gowns and loose trousers can easily get caught up in one's feet, mobility aids, or furniture, and can result in a stumble or fall. Inactivity results in reduced muscle mass, decreased bone density, and poor balance. Vitamin and nutrition deficiencies contribute to weakness, poor fall recovery, and increase the risk of injury from a fall. It is important to monitor a person's food and fluid intake to ensure their nutritional needs are being met. In this next section, we will talk about environmental risk factors. Environmental risk factors are those factors associated with the physical environment, such as the design of a building, entrances and outdoor spaces, and type of furniture and other objects in the rooms. Community hazards are often related to design standards, and building codes may not take into account the needs of older persons. Examples include poor stair design, inadequate lighting, the lack of handrails, the lack of curb ramps and rest areas, uneven pavement due to sidewalk cracks or tree roots, and obstacles on sidewalks that impede safe passage, such as sidewalk furniture, bike racks, grates, and store signage. Unsafe stair design is particularly problematic for those with low vision or mobility problems. Hazards related to stairs include uneven steps, stairs without contrasting edges, lack of handrails, or poor handrail design. Stairs in need of repair, and stairs that are slippery from rain, snow, or moss. Home hazards that have been demonstrated to increase the risk of falling for older people include throw rugs and loose, worn, or deep pile carpets, electrical cords in walkways, raised door sills, cluttered floors, poor lighting, slippery floors, poorly designed tubs, toilets, and fixtures in the bathroom, no aids or poorly installed aids such as grab bars or handrails, and pets that get underfoot. Weather conditions may also increase the risk of falls if appropriate precautionary measures are not taken. In Canada, both temperature and precipitation are factors that can lead to wet or icy surfaces and increase the risk of falling. Winter weather conditions increase the risk of slips and falls, as snow and ice can reduce underfoot traction, making it difficult for all pedestrians to maintain balance and execute effective balance recovery strategies. Freezing and accumulation of precipitation can also create barriers to safe access to roadways, sidewalks, and buildings. These risks are exacerbated when pedestrians increase their walking speed because of the physical discomfort of being cold. Winter weather conditions are also problematic on entry into buildings, as wet footwear can lead to slips on smooth indoor flooring. Such conditions can also prevent effective use of assistive devices, such as gait stabilizers. This includes canes and walkers, which are more likely to slip, and tires on wheelchairs and scooters, which can lose traction or become obstructed. The last risk factor to review today is the socioeconomic risk factors associated with falls in seniors. One's income, education, housing, and social connectedness all bear a strong relationship to one's health, level of disability, longevity, and cognitive function. Individuals with low income, low education, inadequate housing, a lack of support networks, and limited access to appropriate health or social services are all at increased risk of having the chronic health conditions that are highly associated with an increased risk of falling or being injured from a fall. These are certainly social determinants of health, but not as prevalent given the target population in long-term care. Most falls occur as a result of compounding factors that combine and overwhelm an older person's ability to maintain or regain his or her balance. These factors typically represent a complex interaction of biological, behavioral, environmental, and socioeconomic conditions termed risk factors. Research has identified numerous conditions that differentiate between older persons who fall and those who don't fall. Each older person may face a unique combination of risk factors based on life circumstances, health status, health behaviors, economic situation, social supports, and the environment. Understanding what puts a person at risk of falling is a critical step in reducing falls and fall-related injuries among Canadians. In Chapter 4 of this series, we will be discussing strategies for falls prevention. This concludes our module, Part 2, Fall Risk Factors in Seniors. Please proceed to Part 3, Assessment and Interdisciplinary Roles.
Welcome to Falls Prevention Module 3, Assessment and Interdisciplinary Roles. This module is brought to you by Surge Learning. Falls prevention is an interdisciplinary effort with collaboration of the healthcare team, person in care, and the person's family. A resident should be assessed within 24 hours of admission, quarterly according to the RIMDS schedule, annually and when there is a significant change in status. Registered staff are responsible for completing these assessments and updating the care plan. Healthcare aides and PSWs observe changes in health status. They assist and report unsteady residents, report indicators of pain, promote adequate nutrition and hydration, and provide more frequent toileting. The physiotherapist reviews the results of the RIMDS tool as appropriate
and assess residents identified as being high risk for mobility and strength using the following assessment tools, such as the Functional Reach Test. They implement strategies based on the assessment findings, such as gait, balance, and transfer training, and communicate with the interdisciplinary team. They also arrange for appropriate supportive equipment, supplies, devices, and assistive aids to prevent falls, and participation in nursing, restorative, or rehabilitation activities in collaboration with nursing. The physician conducts a medication review and possibly considers a bone supplement. Activation assesses activity patterns and pursuits, engages the resident in activities in collaboration with nursing, and engages the resident in recreational programming, such as group programs or one-to-one programs. They also assess the need for or consider a referral to a one-to-one visiting volunteer. The resident substitute decision maker and/or power of attorney ensures that the resident has proper footwear and ensures that they have appropriate eyeglasses and hearing aids. They also provide a history outlining past falls, special needs, and medications. So what do we do when a resident has fallen? After a fall has occurred, the registered staff will perform a head-to-toe assessment. They assess the level of consciousness and determine the need to transfer to the emergency room. Do not move the resident until appropriate action has been determined based on assessment, and provide immediate treatment, such as first aid. A head injury routine should be performed for all unwitnessed falls and for witnessed falls that have resulted in a possible head injury. For a possible head injury, check the vital signs every hour for 4 hours and then every 4 hours for 24 hours. Be sure to notify the physician and the substitute decision maker or family on the day of the fall. After the fall, the healthcare aide or PSW can assist the registered staff as needed. They observe the resident and physical environment and complete a post-fall environmental screening tool. They transfer the resident once the assessment has been completed and to provide comfort to the resident. If there is no loss of consciousness, no head trauma, and only minor hematomas and lacerations, the registered staff will check vital signs at the time of the fall and as assessment warrants. If the person is diabetic, be sure to check the blood glucose levels. Anticoagulants monitor 24 hours and observe for possible injuries not evident at the time of the fall. Registered staff will observe for mental status changes and determine if restrictions to mobility appear warranted. Determine the circumstances leading to a fall, such as the cause of the fall, and meet with the interdisciplinary team to prevent reoccurrence. Redo the falls assessment and post-fall assessment. The healthcare aide or PSW will monitor the resident with frequent safety checks, carry out interventions to prevent reoccurrence, and report changes in condition to registered staff. An interprofessional team will investigate the cause of the fall and refer to the appropriate team member to implement actions that will prevent the reoccurrence of another fall. So what exactly do we document when a resident has fallen? We need to note the time of discovery, the time that you witnessed the fall or found the person on the floor, if unwitnessed. What was the appearance of the person at the time of the discovery? Were they in distress? Were they in pain? Or were they disoriented? What were some of the environmental factors at the time of discovery? Was the lighting poor, or were there any trip hazards? Be sure to note the response to the event. What was your response? What was the response of the person who had fallen? What were they doing prior to the incident, and what risk factors are present? Is there any evidence of injury, such as cuts or fractures? Be sure to note the location of the fall. Did they fall in their bedroom, their bathroom, or common area? Note any communication with the physician or substitute decision maker. When did you call them? Did they answer? Did you leave a message? And what was their response? Be sure to note any medical and nursing actions. What actions or interventions took place? In the event that an injury has been sustained and the resident was taken to hospital, resulting in a significant change in their condition, you must complete a critical incident form. Be sure to notify the family, power of attorney, or substitute decision maker. Review fall prevention interventions and modify the plan of care as indicated. And be sure to communicate to all shifts that the resident has fallen and is at a risk to fall again. Be sure to update the resident's individualized plan of care. Review if one or more of the major risk factors on the RAP are present, for example, psychotropic drug use, previous falls, and dizziness. Include the falls RAP if the resident has one of 5 of the following: wandering, previous falls, psychotropic drugs, dizziness, or restraints. Note if the resident has had multiple falls. You can refer to the MDS, reports from family, and incident reports to get this information. Identify internal and external risk factors. And what appliances and devices are in place to minimize the risk for falls and minimize fall-related injuries. Be sure to also capture environmental and situational devices used. Thank you for joining us. This concludes Module 3 of our Fall Prevention series. Please proceed to Module 4, where we will review strategies for fall prevention. A resident should be assessed within 24 hours of admission, quarterly according to the RIMDS schedule, annually and when there is a significant change in status. Welcome to part 4 of this Falls Prevention series, Strategies for Fall Prevention. Prior to this e-learning module, hopefully you have reviewed and are familiar with the prevalence of falls, risk factors for the senior population, and assessment prior to and after a fall occurs. This chapter will review some strategies to minimize or prevent the occurrence of falls and fall-related injuries. This presentation has been brought to you by Surge. Please also familiarize yourself with your organization's policies and procedures for your falls prevention program. In this module, we will review some general interventions that should be considered. However, keep in mind that each person in your care is unique, and interventions vary from person to person. Prior to implementing any interventions, the person in care should be assessed for fall risk, and keep in mind that an interdisciplinary approach should be taken. This slide highlights some of the key strategies in reducing the incidence of falls and fall-related injuries. Strategies reducing the incidence and prevalence of falls and fractures include exercise programs, environmental modification, education, medication review and modification, clinical intervention, assistive devices and protective devices, multifactorial intervention, and the prevention of fractures. In the following slides, we will be reviewing each of these. Inactivity and disuse of muscles are significant contributors to muscle deterioration. High-resistance weight training for elderly and frail individuals results in significant muscle strength gains and enhanced gait stability. The muscle strength training program involves a progression of strengthening exercises for the major muscle groups of the body. Regular exercise can provide opportunities for social interaction, better the sense of well-being, improve sleep quality, increase bone density, improve mobility, and enhanced independence. A physiotherapy program might include 3 types of therapeutic exercise: muscle strengthening, balance training, and flexibility exercises. Environmental modifications might include rearranging the layout of furniture, appliances, and medical equipment in the facility and the resident's room. Adjust the heights of beds, chairs, tables, and other furniture that may contribute to a fall risk. Remove trip hazards such as throw rugs and electrical cords, and adjust lighting in the resident's room and within the facility to ensure comfortable visibility. Let's take a moment to practice our knowledge on environmental modifications. Click on any of the following environmental modifications that can help minimize or reduce one's risk for falls. Click Submit after you have made your selections. That's right, you selected the correct response. Fall prevention also includes education for both staff and the person in care. Education around fall risks through information campaigns and health promotion activities is one approach, as well as education to reduce the fear of falling, to improve or maintain participation in activities of daily living and leisure activities. It is also important to instruct staff and the person in care on the use of assistive devices and the mobility aids that they will be provided with, to ensure that an overall comprehension of the use and purpose of the devices or mobility aids are understood. There is insufficient evidence to conclude whether education alone is an effective intervention, but it does play a role as a part of a multifactorial strategy that includes clinical assessment followed by targeted intervention. Taking 5 or more prescribed medications is a significant factor in many falls. Interventions might include helping seniors withdraw from benzodiazepine and other drugs or altering prescriptions to avoid interactions. Residents can also take calcium and vitamin D supplements or bone-enhancing medication, especially for those with documented osteoporosis. Clinical assessments by registered staff and physicians should be completed to identify seniors at a high risk of falling. Screening for cognitive and physical fall risk factors are often combined with interventions to reduce behavioral or environmental risk factors. The correct use of walkers, canes, scooters, and other devices can be effective in minimizing one's risk for falls. The use of hip protectors to cushion the hip can also be used to minimize injury that results from a fall. Based on assessment results, assisted devices and mobility aids may be recommended to residents to improve mobility and participation in activities of daily living. Education on the use of assisted devices and mobility aids will be provided to the staff and the residents to ensure an overall comprehension of the use and purpose of the device or mobility aid. The use of these devices will be practiced and monitored to enhance safety. Multifactorial intervention involves combining many interventions, such as one or all of the following: exercise programs, environment and behavior modification, medication review or adjustment, and the use of assisted devices and clinical assessment. Evidence shows that preventing falls requires interventions that target more than one risk factor. Clinical reviews have emphasized the importance of maintaining and enhancing bone density and preventing osteoporosis with calcium and vitamin D and by taking bisphosphonate drugs. This is in addition to modifying other risk factors for osteoporosis, such as sedentary lifestyle, poor diet, smoking, and alcohol use. Some strategies to prevent the reoccurrence of falls include trying small changes one at a time to determine what works to reduce falls. For example, the Quality Improvement Methodology Plan: Do, Study, and Act. Ensure that appropriate interventions have been taken, for example, lowering the bed, uncluttering the room, and rest periods in the afternoon, and that the interdisciplinary team is aware. Residents may choose to live at risk and maintain their independence. We need to try to work with them to prevent serious injuries from falls. Details regarding the residents who are falling can be found in the QI data from your clinical software and other internal tracking systems. Registered staff will recognize trends with individual residents and initiate an interdisciplinary discussion regarding possible interventions. For example, Mrs. Smith is falling in the bathroom between 6 o'clock and 7:30. She has had 5 falls in the last month. Maybe change the care plan and communicate to toilet her at 6 o'clock. When preventing reoccurrence of falls in your care facility, it is important to measure the prevalence of falls, serious injuries arising from falls, and your restraint utilization rate. You can also look at physiotherapy and nursing restorative data. For example, the number of residents who have fallen that are participating in an exercise program, and residents whose function has improved due to physiotherapy or a nursing restorative program. It is important to monitor and evaluate the effectiveness of your fall prevention program. Consider these key questions. Is our program working? Are we noticing a reduction in falls and fall-related injuries? Are there new best practices being used to address fall prevention and management? And what changes can we make to our programs to achieve better resident outcomes? In this knowledge check, click on each of the following interventions used in fall prevention and preventing fall-related injuries. Once you have made your selection, click Submit to continue. That's right, you selected the correct answer. This concludes Module 4 of our Falls Prevention series. Please remember that most falls occur as a result of compounding factors that combine and overwhelm an older person's ability to maintain or regain his or her balance. These factors typically represent a complex interaction of all factors: biological, behavioral, environmental, and socioeconomic conditions. Each older person may face a unique combination of risk factors based on life circumstances, health status, health behaviors, economic situation, social supports, and the environment. Understanding what puts a person at risk of falling is a critical step in reducing falls and fall-related injuries among older Canadians. Be sure to regularly assess one's risk for falls and develop strategies with an interdisciplinary approach. Communicate the risk and strategies in the person's plan of care and ensure there is ongoing evaluation of the person's level of risk, interventions being used, and the effectiveness of your falls prevention program. Thank you for joining us for this series on falls prevention. Please also familiarize yourself with your organization's policies and procedures.